You are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. Welcome to the ladies' room. You know, we have discussed breast cancer a lot from many different perspectives on this show. First, we had Leslie Jane Seymour talking about her concerns about whether being on hormone replacement therapy would increase her risk of breast cancer in episode 5. Laura DeAngelis talked about being a breast cancer warrior for awareness and early diagnosis in episode 7 after her mom went through breast cancer treatment and one of her best friends died at 42 years old. Dorothy, the organizer, talked about being a caretaker for her sister who had advanced end-stage breast cancer in episode 6. Beth Battaglino, CEO of HealthyWomen.org, talked about their Keep the Care campaign so that all women in the United States could continue to have access to covered breast cancer screenings without out-of-pocket additional expenses in episode 17. In episode 26, Jennifer Wyckoff talked about her journey as a previvor who was found to be BRCA2 positive thanks to those preventive screenings in her 30s and the steps she's taking to reduce her risk of breast cancer. In episode 24, we talked about with Donna Hopkins, a heroic woman who fought and overcame breast cancer twice, only to subsequently lose her leg to the unexpected consequences of a relatively common elective surgery. But today is the first episode where we're talking to a physician expert who not only takes care of women with breast cancer at all stages, but who's also conducting important cutting-edge clinical research into new therapies. She's joined by a breast cancer survivor who also chose to participate in a clinical trial as part of her treatment journey. Now, why are we talking about breast cancer so much? Not only is breast cancer arguably one of the most feared diseases of all women, it is common. Every year in the United States, more than 250,000 women, 250,000, will be diagnosed with breast cancer. And while our treatment options have advanced significantly, more than 40,000 women per year will still die of breast cancer. However, we still haven't really educated women to a great extent about the fact that breast cancer is not just one single disease. There are many different types of breast cancer, which range in severity, aggressiveness, and responsiveness to various treatment protocols. Up to 20% of women, 1 in 5, have the more aggressive form of breast cancer called HER2 positive breast cancer. Here to explain what's being done to treat it, and hopefully to keep it from recurring, are Dr. Denise Yardley, Senior Investigator of Breast Cancer Research Programs at Sarah Cannon, the research arm of HCA Healthcare's Global Cancer Institute, and breast cancer survivor, Dr. Allison Fields. Now, to tell you a little bit about our guests, Dr. Denise Yardley joined Sarah Cannon in 2000. She's a graduate of Columbus State University and the Medical College of Georgia. She completed her residency and fellowship training at the University of Texas Southwestern Medical Center in Dallas. She has all kinds of distinguished awards, but most importantly, she's a diplomate of the American Board of Internal Medicine, Medical Oncology and Hematology, and is also a recipient of the American Cancer Society Clinical Oncology Career Development Award. Now, Dr. Allison Fields is a 47-year-old veterinarian with a strong family history of breast cancer. Both her mother and grandmother were afflicted by it. When she was diagnosed with an aggressive form of early breast cancer, Allison decided to participate in a clinical trial investigating how women with HER2 positive breast cancer, and yes, we're going to hear all about what that is, how she responded to treatment after surgery. Now, while clinical trials remain a mystery to many people, as a medical professional, Allison knew that not only could she personally benefit from the trial potentially, but she saw it as an opportunity to help others. Now, 4 years later, she's healthy, continuing to practice veterinary medicine, and enjoys traveling, most recently to Iceland to view the Northern Lights. Please welcome Dr. Allison Fields and Dr. Denise Yardley to the ladies' room. Hello, ladies.
Hello.
Welcome. And I'm sorry that we have 2 wonderful guests today, but we have half the normal time that we have to discuss this. So Denise, please just jump right in and tell everybody what is HER2 positive breast cancer.
So HER2-positive breast cancer comprises about 15 to 20% of all new breast cancer diagnoses. It really refers to a specific feature on that breast cancer tumor cell. It's a protein on the surface. And the real importance of identifying this as a specific subtype of breast cancer is that there have been great scientific understanding of this feature of the tumor. And we have now specific drugs that are approved only for the HER2-positive breast cancer. And so that's really the importance of identifying that subtype so the appropriate recommendations for treatment can be made. And, we're here today on behalf of Genentech to talk about one of the latest, greatest approvals that occurred in December 2017, of Perjeta added to Herceptin in the treatment of early stage HER2-positive breast cancer. And this drug has side effects of rash and diarrhea, but for the appropriate early stage HER2-positive breast cancer patient, it's been shown to improve the outcomes and increasing, the cure rate for patients facing a diagnosis of breast cancer.
Well, that was a mouthful. So explain to our listeners, what does HER2 actually stand for?
So HER2 stands for Human Epidermal Growth Factor Receptor, and it's abbreviated as HER.
Because we abbreviate everything in medicine.
That's right.
First, we come up with really complicated names for things, and then we abbreviate them. So, and Allison, were you in this particular clinical trial?
I was. It was a double-blind study, so she didn't know and I didn't know if I was actually getting the drug that was designed to attack that whole HER2 problem that we had.
And was this completely double-blind, or was this a crossover study?
No, it was completely a double-blinded trial.
Okay. So in a crossover trial, many patients, one of the things I always want to talk about is how we get more patients to participate in clinical trials. We know that from the general population, only about 4% of people have ever been in a clinical trial. And with women, it's generally fewer than men, not because we're not as willing or interested in participating in clinical trials, as Allison can attest, but until relatively recently, not many clinical trials were open to women. So that's a whole nother subject. But Allison, I want to talk about what motivated you to be in a clinical trial, because one of the things we often hear from cancer patients is they don't want to be in a clinical trial because they don't want to risk getting the placebo. They want to make sure that they're in the treatment group.
Well, if you don't want to risk getting the placebo, you've also thrown out the window the possibility of getting the drug. Mm-hmm. So you're cutting off your nose to spite your face if you don't want to be in a trial because you might get the placebo.
So you mean the possibility of the drug then becoming available to the general public?
Yeah.
Okay. So how did you find out about this clinical trial?
I actually have a family friend who is in oncology research who had told me about it, and he lives on the other side of the country, and he told me who the lead investigators were, and Dr. Yardley was one of them, and so I tracked her down.
Yeah, because I was pretty shocked to read a 2016 report that surveyed over 2,500 people and found that fewer than half of them had ever even heard of clinical trials. And of those people, only half of them had said that they had ever even heard of an advertisement for a clinical trial. And yet the pharmaceutical industry spends over $2 billion a year with clinical trial recruitment. And often that's very sluggish. It's slow. It's a rate limiting step, as you know, certainly, Dr. Yardley. And this is something we need to do a better job of. So Allison, I give you a lot of credit for being in it. How long was the trial that you were in?
I think I'm technically still in it.
Okay. Good.
So
and what is, and what is your
phase was, she completed the treatment phase, but the follow-up continues for the patients.
Great. So when can we expect to hear the results of this trial?
So we've already had the first look at the data for the trial, which was a positive trial, and it led to this FDA approval in December. But the follow-up continues for some of the other secondary objectives for the clinical trial. So the long-term data is still in progress by following the patients.
Every time I see her, she says, okay, and so I think we're going to do this for 5 years. And the next time I see her, she'll say, okay, and so we're getting good stuff back in 10 years. And then the next, I think the last time we were up to 15 years. So, I'm sure
she's a long-term thinker.
She is.
And you have to be to participate in clinical research. And of course, Allison, I would love to hear about your journey to Iceland. But the journey that most people really want to hear about was your journey from diagnosis to treatment. So how old were you when you were diagnosed with breast cancer?
I was 42, the same age that my grandmother was when she was diagnosed with breast cancer. Both my grandmother and my mother had breast cancer. So when I was diagnosed on a mammogram, I knew that this was probably not good, and without even biopsy, and took steps to figure out what type of cancer it was, and then to try to figure out what doctor I needed to see to best deal with my type of breast cancer.
And
so I had...
And how old were you when you started having mammograms?
40.
Okay. So this was the second year.
Yeah. So I chose to have a bilateral mastectomy. So both my mother and my grandmother had a mastectomy, and then they had reoccurrence or a new tumor and had another mastectomy, and I was like, nope, don't have time for that. So I did bilateral mastectomies followed by chemotherapy and radiation, as well as the clinical trial. So my goal was to do as much as I possibly could to kick its butt.
And you did, and you are.
Yeah.
And what is your status now?
I don't know. Let's ask the doctor. I think I'm good. I'm 5 years out, and they can't find anything wrong with me other than my smart mouth. So we're good.
All right. And so we have an abbreviation for that also. We call that NED, or no evidence of disease, which I think is the three favorite letters of all people who've been treated for any kind of breast cancer or any kind of cancer, actually, is when they hear that NED. From their radiologist or from their physician, which is, wonderful news. Now, had you been tested for the BRCA1 or BRCA2 genes?
I have, both my mother and I, and we are positive for, I forget which one. One of them? BRCA2. There you go.
Okay. Did you know that before your breast cancer diagnosis, or did you only find that out after?
I found out maybe a couple years. No, I guess it was after.
Right after.
Yeah, my mom had just found out like a year or two before, and as soon as I was diagnosed, we sent that off.
Okay. And do you have sisters?
I do not have any sisters. My aunt, my mom's sister, is negative. She got tested, so that side's good.
That is awesome. So, Denise, tell us about some of the other advances in breast cancer therapy.
So I think, the important part for us is to really figure out the subtypes, as most of our treatment recommendations now are coming very specific. So I think we used to approach breast cancer for the one size fits all, and now we've been able to identify like the HER2 feature and that signaling pathway and the specific drugs like Perjeta, Herceptin that work. For the triple negatives, we're looking for specific drugs. There's lots of research. I think on the forefront that's quite exciting, both in combination with HER2 therapies for triple negative, is the immunotherapy, which has really blossomed in many of the other subtypes of breast cancer, and still in clinical trials for breast cancer patients. But I think there's a lot of enthusiasm for that moving forward.
Now explain to people what triple negative means.
So triple negative means when we look at that particular breast cancer, it does not have the HER2 feature on the surface of the cancer, and it doesn't have those hormone receptor features, the progesterone and estrogen. So it's considered triple negative. It has a total absence of any of those receptors. And so it's been a little bit harder to develop a target since it doesn't have a feature on the surface of the tumor cell.
Or a feature that we've discovered yet.
Correct.
I guess you and your colleagues are still working on that. So we'll have a podcast episode in the future when we're going to be talking about that. So, I think we have a lot of people listening, certainly, who have had breast cancer. We have a lot of people listening who have had a family history of breast cancer. But I think the majority of people listening have not yet had any cancer diagnosis. And one of the things we talk a lot about are the things that people can do to reduce their risk of developing cancer. And we used to have a very fatalistic view of this, or say, focus on smoking. It's obviously nobody should smoke for any reason. I think it's the only thing that 100% of doctors agree about. or smoke cigarettes. I guess now we're agreeing that maybe smoking some other things might actually be helpful in certain circumstances. But what other things can women do to reduce their risk of breast cancer?
So I think one of them is looking if there is a family history. There are some genetic tests now that we can offer patients that can get screened to see if there's a hereditary predisposition. I think the other things that we really talk about is maintaining a healthy body mass index. So really trying to focus on maintaining that weight. And exercise, aerobic exercise, 2 to 3 hours a week has really been shown as another tangible thing that patients can do on their own to help reduce the risk of having breast cancer.
And the exercise is independent as a preventive risk factor from the body mass index variable.
Yes, correct. Absolutely.
Okay. And talk to me about alcohol.
So alcohol, has definitely emerged as a moderate or mild risk factor to be limited to, most of the recommendations say a drink a day, so no more than 7 a week. So I think there's definitely moderation with that because the issue is how it processes some of the body's hormones through the liver that may offset or put somebody at a slightly increased risk.
Okay. Now, we did talk to a woman who we're calling a previvor, who was diagnosed as being BRCA2 positive before developing breast cancer. And she chose to go the Angelina Jolie route of, having a prophylactic bilateral mastectomy. She has not yet had oophorectomies or had her ovaries removed, but has had her fallopian tubes removed, which is actually kind of a relatively new thing that we've learned about ovarian cancer, is that it often starts in the fallopian tubes. And this was a very young woman, so her doctors did not recommend that she have her ovaries removed yet. If you had seen Allison before she was diagnosed with breast cancer, and if she knew that she was BRCA2 positive, what might you have recommended to her at that time?
I was just going to say that was my plan.
Okay.
I was planning to get tested as soon as my mom got tested, and I knew that. And my plan was get tested. If positive, I was going to do a prophylactic bilateral mastectomy. Life, work. I mean, I think I decided that when I was 40, and I was diagnosed at 42. So I didn't do what I had wanted to do in a timely manner. And had I never would have met Dr. Yardley, hopefully.
And you wouldn't have been in this clinical trial. And most importantly, correct, you wouldn't have been on this podcast.
Right. So my slackedness, I just I told myself I was going to do in the time frame that I was trying to do it in. And had I done that, I totally would have gone that route. Mm-hmm. Absolutely.
And do you mind if I ask, have you had a discussion about what you're going to do about your ovaries, or?
Oh, they're gone.
Oh, okay. And that was part of this process, or that was independent?
It was recommended as part of this process. So when I had my finishing of my reconstruction, I had them schedule that at the same time. So I went in and had breast reconstruction finished, ovaries out, my port out. All the doctors came and got me while I was sleeping.
So, and what age were you at that time?
I was 42.
When you had everything, all the surgeries and everything, it was all the same year.
I was 43 for the second one. So I was 42 on diagnosis and mastectomies, and then 43 for the finishing touches on the breast reconstruction, the ovary, an oophorectomy is actually the proper term, the oophorectomy and all of that.
Yeah, ovaries out. And did you keep your uterus in, or you took that out too?
I currently still have a uterus.
Okay.
Did not feel
you're the proud owner of a uterus.
Yes.
So a lot of women are very confused. The reason I ask is a lot of women are confused about what an oophorectomy is, what a hysterectomy is, because back in the day, 100 years ago, when Denise and I were in medical school, we routinely when we took out the uterus, we routinely took out ovaries as well. And so a lot of women thought that having a hysterectomy meant having all your parts taken out, which is not accurate. So you can have them.
Unfortunately, that's not something that we have to do these days. And it's,
right.
So, Denise, what is the difference in risk for ovarian cancer with BRCA1 versus BRCA2?
So the risk for ovarian cancer is higher with BRCA1 and much less with BRCA2, and it's a later event than the breast cancer. So we really do address targeting identification of imaging for breast cancer, and the ovary removal comes usually later in life after childbearing or closer when the menopausal symptoms aren't so bad. So I think at this point, we're going to have to thank you for the participation. And then if any patients, or some of the listeners want to get more information, we like Living Beyond breast cancer, lbcc.org for more information.
Okay, that is wonderful. Thank you so much for coming. And we wish you great success with your clinical trial. And Allison, we wish you great success with continued health and continued wonderful travels. And thank you for all you do to take care of so many people's pets.
Thank you very much.
Take care. Thanks for coming to the ladies' room. Bye-bye.
Bye-bye.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. And please join us next week for another episode of In the Ladies' Room with Dr. Donica. Real conversations with real women about really intimate topics. That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. And please join us next week for another episode of In the Ladies' Room with Dr. Donica. Real conversations with real women about really intimate topics.